Haber. You know who she is. Raise your hand if you don't know who Dr. Haber is. Dr. Mary Claire Haber is a board-certified OBGYN, a fellow of the American College of Obstetricians and Gynecologists, a Menopause Society certified practitioner, and the founder of The Pause Wellness, a private medical practice dedicated to the care of women in midlife. She is the #1 New York Times bestselling author of, you can probably all say it in unison, The New Menopause and the Galveston Diet. She is the creator of the Galveston Diet, which is the first nutrition program designed by a female OBGYN specifically for women in perimenopause and menopause. With over 7 million social media followers and a global platform built on practical, science-backed guidance. We always like when there's little science. Might not be popular these days, but we like science. Dr. Haber, that fan in their science, Dr. Haber is among the most influential voices working to transform the culture of women's midlife health care. Joining her is one of our favorite people, Heidi Stevens. She is a Chicago-based writer and the Director of External Affairs for the University of Chicago's TMW Center for Early Learning and Public Health. Prior to joining the UFC, Heidi worked at the Chicago Tribune for 23 years, where she wrote a daily column called Balancing Act. She was awarded the Ann Keegan Award for Distinguished Journalism in 2018. She now maintains a nationally syndicated weekly column and has served on the fan board since 2021. Let's give a big welcome to Dr. Mary Claire Haber and Heidi Stevens.
I guess looking at this crowd, I'm thinking of you writing in the book that this is a generation that's not going to be shamed into silence.
No. I think you guys have kicked the door down.
Yeah, love it. Okay, so we have a lot to get to. I hope that we could start by maybe explaining and debunking this study that came out in 2002 out of the Women's Health Initiative that probably informed how a generation or two of women experienced menopause, talked about menopause, still probably have floating around their heads about hormone replacement therapy. So talk about that study and just put it into some context for us.
When the study was conceived, the new head of the NIH at the time was a woman. And there had never been a large-scale study done on women outside of pregnancy that was NIH funded. So what we knew from observational studies at the time was women who were on hormone therapy, which back then in the 90s was mostly Premarin or Prempro. That was the preferred formulation at the time. We don't really use those anymore, but it's important in the context of the story. And so they said, well, we know from observational data that women who take this tend to have less heart attacks and maybe live a little bit longer. Is this real? So observational data is we just look at some charts and look at trends, but the way we prove things are with randomized placebo-controlled trials, okay? That's the gold standard. She convinces the NIH to do this beautiful study, which was to say, does hormone therapy, we know it stops hot flashes, we know it helps your bones, that was never in question. Does it really prevent heart attacks? Or are these women just healthier and wealthier and they have more access to healthcare? Is this an artifact of patient selection, or is this, a real deal? So they go and recruit, they get a billion, a lot of zeros, however many math, to do this study, which was huge. I remember the recruitment process. I was a resident at the time, and we were so excited, right? They're finally gonna study women outside of pregnancy, for health, and I think it was 34,000 patients were recruited. Because the end of the study aim was heart attack or no heart attack, they started with an older population. The average age was about 63, okay, much older than a woman would typically start hormone therapy. They excluded women with hot flashes because they would know if they were on placebo or not, because their hot flashes would stop. So it was kind of an unusual population to study, menopause, and they wanted an older population because it takes a while for a woman to develop a heart attack, and the study would have been too expensive and too long if they would have started at 50, which is the average age that a woman at the time was starting hormone therapy. So they recruit, they start, placebo. So there's basically there's two arms, 4 ways. Placebo medication. If you had a uterus, you got estrogen and a progestogen, okay? And at the time it was medroxyprogesterone acetate or something we call Provera with the Premarin, or you got Premarin alone if you didn't have a uterus versus placebo. off we go, we start measuring, collecting data. There was an early signal in the data for the estrogen and progestin only arm after about 3 years that suggested perhaps it wasn't statistically significant, okay? And in science, if it's not statistically significant, it doesn't matter. That they saw, it looks like there's maybe more breast cancer in these patients. There's a lot of politics involved here, a lot of egos. There were 17 centers involved in the trial, but some of the lead investigators got together and held a press conference and released results without the entire team really looking at it, or there was no meeting called to kind of evaluate it, and basically called a press conference in DC and said estrogen causes breast cancer. And that genie got out of a bottle. It was the biggest medical news story of 2002. I remember it was July, and I was at the end of my residency, and like the world was imploding. Like people were freaking out about this, and patients were calling and so scared, because at the time about 40% of women were utilizing hormone therapy, and now, it was on the cover of every major magazine, every newspaper. There was no internet back then, but it went viral, and people threw it away, and that was hard to undo. Now, in the ensuing 24 years, so much of that has been reevaluated, analyzed, and I don't want to demonize a data set. It's just numbers, right? And so what we've learned is the estrogen-only arm had a 30% decreased relative risk of breast cancer. There was something about probably the progestogen they were using that may have been a mild signal, but it was still like 4 out of 10,000 women difference, right? Versus, all the women being taken off, the genital urinary syndrome of menopause that ensued from that, from women being scared, all the osteoporosis, that ensued from that, from women not being given the option to protect their bones using estrogen. Yeah. And so the black box warning was slapped on, and it went on all estrogen products, except for birth control pills, including vaginal estrogen, which wasn't even part of the study, and so what we know now, and so all of that taken aside, most of that has been walked back. For the vast majority of patients, hormone therapy is not for everyone, right? But it should be a discussion for everyone. Right. You should have the option. It is safe. The benefits will far outweigh the risks for most patients. Mm-hmm. And that message has taken almost 25 years to walk back and have a more reasonable discussion. Yeah. And it still floats around in people's minds. It still floats around in I still have to kind of talk to patients off the ledge, even though they follow me and they watch the videos and they read all the books. I'm lucky in my practice that they come in drinking the Kool-Aid, but I still have to reassure them. Of course. Because they were just so scared for so many years. Of course, yeah. Well, thank you for putting that in context, and I think it's a good sort of level set for the evening. And something that what you just said about the 24 years makes me think in the book that you wrote that it can take 17 years so there for research to translate into office practice. Yeah. So I think it's getting faster because the way we are able to research now, utilizing tools like AI, to gather up sort through articles faster. I certainly use open access, and I use something called consensus.app, which are, instead I'd have to go to the library and make copies and highlight and underline, and this just allows you to pull multiple articles at once and compare and contrast. So I think that's getting faster, and that a lot of these articles are open access. Patients are getting more educated, more interested. But when the study was done, for a discovery to be published, for that to filter down into actual clinical practice is 17 years. 17 years. Yeah. And so for a guideline to change, and then those guidelines to get, the doctors to go to the next clinical meeting or get the magazine or take the test, it takes a long time. Yeah. So for any of us who are here tonight feeling a little bit confused about menopause or left in the dark about menopause, I just think that's useful context, right? There's a reason why the latest research may have not caught up with your specific clinician, why you haven't been able to find the latest research necessarily. So, and another thing, how many clinicians are out here? Do we have a lot of docs, NPs, MPAs out there? Yeah, I see some hands. Hi. Welcome. I received in medical school, and I went to med school from 94 to 98. I think we had 1 hour lecture on menopause. Okay. That's what I thought of menopause, 1 hour. And then I did my OBGYN residency, and I learned some amazing stuff in OB-GYN. I love my training, everything about it, and it took me 15 years of clinical practice to realize there was a big gap in my knowledge. I learned how to pronounce perimenopause, and I could like circle ABCD on the test with the definition, but we didn't learn anything about it, like how to manage it, what it really meant. I just thought it was this slow, gentle decline of ovarian function until the ovaries just petered out at menopause. I didn't even know where the locations of the estrogen receptors were in the body until 5 years ago. Wow. Like I knew there were breasts, I knew uterus, I knew ovaries, I knew bones, right? But I didn't realize the endothelium, our ear canals, our,
every single organ every system cell of our body. Organ, right? Yeah.
I mean, I knew the genital urinary system, but like how when the rock and roll that happens, the chaos in perimenopause and then the flatlining in postmenopause, just how that would hit so many areas of our body.
So many areas of our body. And yet many of us believe that the thing that will change in our body is our period.
Well, that is one thing, for sure.
One, but not the only.
But not the only. Yeah. That and hot flashes. So when you look at what we call straw staging, how I was taught to define the stages of menopause, like from perimenopause all the way through, there are like 4 criteria. One is the menstrual cycle, one is vasomotor symptoms like hot flashes, and the other is a couple of lab results, which are kind of all over the place. And then they flatline or go up in postmenopause. And that's it. Nothing about mental health, nothing about cognitive changes, nothing about sleep disruption, nothing about hearing your husband chew really loud. Like the things that are really affecting women as well.
Right.
Yeah.
So if you go to your doctor and you say, I just am not feeling like myself,
right.
or I want to murder my husband when he chews, unless you have hot flashes and an irregular period,
they weren't
he
taught
or she may not ask you about.
And for a very long time, that was me. I was never taught to connect the dots. Yeah. And even the cycle irregularity, I kind of just thought they stopped. Like I knew that women close to menopause would have some cycle irregularity, skipping mostly, but the heavy cycles and the frequent cycles, like really outside. I know we called it dysfunctional uterine bleeding, but I wasn't connecting the dots that this was a predictable biological response to the hormonal chaos of perimenopause. It was always pathology, and sometimes it is fibroids and polyps or a combination of all these things, but like really thinking about this cycle irregularity, this menorrhagia, this stuff that is like disrupting her work and she's anemic and, just really disrupting her life is predictable.
Yeah.
That 80% of us will have this kind of bleeding as we get closer to menopause.
The zone of chaos was actually predictable. Mm-hmm. Yeah.
But I was just taught women are a little bit crazy. And maybe we are, and that's fine.
What?
But it was I'm going to quote Elizabeth Coleman, who calls it the bitches be crazy school of medicine. So that women just somaticize psychological symptoms.
Yeah, that's
just part of the female experience. Yeah. And I was like, okay. Until it happened to me.
Yeah.
And then I was like, wait a minute. Okay. I'm not okay.
That was what changed, was when it happened to you. That's what changed your...
That and my friends were going through it at the same time. And I know these women. I ran marathons with them. I went to dinner with them. We picked up each other's kids. We did all the mommy groups and, and book club. And I knew them inside and out. Yeah. And I knew that they weren't gaining weight because they were eating more and lazy. I knew that they were struggling, so many of them, with mental health. Yeah. We see a 40% increase in mental health disorders across the perimenopause transition. Yeah. And that's really what made me, and the weight gain. Yeah. And so for me, it was vanity, like I've enjoyed thin privilege most of my life. And then all of a sudden I was like, what is this? Like, why won't it go away? And all the usual things that, little tricks we do to get back into our jeans or bathing suits wasn't working. And I was hearing the same thing over and over again from my patients. So.
And the average age of perimenopause begins when?
That's a great question. So if we look at the average age of menopause, which is no more periods. So if you don't know why menopause happens, female humans are born with their entire egg supply. Okay? And when you're 5 months in utero, inside your mom, is when you have the most amount of eggs. And then they start going through a process called atresia immediately after they're formed. So by the time you're born, you've got 1 to 2 million eggs. And then by the time you're 30, you're down to 10% of that egg supply. And by the time you are 40, you're down to about 3%. And menopause is basically no more functional eggs left. You're done. And you have to live the next 30 to 40 years, if you're lucky, without the benefit of your ovaries. And so if menopause is like no more eggs, what is perimenopause? Well, think of ovulation. So most of us in biology class have seen the ovulation chart, right? The egg drops right in the middle of the cycle, and your estrogen is at its highest, and it drops down. Then we have a progesterone surge after that, and the whole system kind of restarts month after month after month. And in a healthy premenopausal, menopause has not entered the chat, eggs are fine. We have some kind of regular period, right? 25 to 31, 32 days, whatever your normal cycle is. And it's very predictable. On day 18, your levels tend to be this. On day 14, and the ovaries are kind of dumb. They just sit and wait for instructions. They don't have a brain. They're just there, and they have lots of receptors on them. And so the brain is actually telling the ovaries what to do. And when our estrogen levels drop off in menopause, after ovulation, the brain's like, woo, where's that estrogen? I'm looking for it. Okay, so it sends a signal to the ovary to ovulate again and start that whole process. So we have LH and FSH, and then estrogen and progesterone. So we get these very predictable, almost EKG-like changes. When we reach a critical egg threshold level, at the beginning of your perimenopause, ladies, which for all of us is a different age, the signals coming from the brain don't work as well because we don't have enough eggs to respond the way we used to. So signal goes down as usual, and the ovary is like, I'm trying, but it's not really working. And the brain's like, where's my estrogen? You know? And the ovaries are like, you sent me the signal. And so the brain starts sending higher and higher levels of these stimulating hormones. So that's taking more time. So we see delayed ovulations. When we do ovulate, because there's so much stimulating hormones, sometimes we'll get double ovulation or loop ovulations kind of back to back with no progesterone between the two. So what used to look like an EKG is now I take 4 strands of spaghetti and throw them at the wall. And, we have these super high surges of estrogen, then these massive crashes, and progesterone is really struggling to keep up. It never is reaching those, very predictable levels like it used to.
Yeah.
The brain hates all of this, okay? Yeah. And so symptoms in perimenopause, so the ages, so if average age for a woman who looks like me actually is 51 in the US, for someone who looks like Samina, it's 46, okay? So there's genetic variation in our ages for full menopause.
For full menopause.
Peri begins 7 to 10 years before that.
Okay.
So back up those numbers. So still, there's a lot of variation in when every woman goes through menopause. So normal is still 45 or 46 to 55 years old. So there's a big, variation in when we're each going to be finished.
Okay.
Now back those numbers up 17 years. So sometime in your 30s or 40s is when perimenopause will begin. And the first symptoms tend to be in the brain. Cycle irregular, you're missing your cycles, heavy periods, that tends to start late, like within the last 2 years of perimenopause.
Okay.
Because
it lasts like 4 years, right? Ish, yeah. 4 to 7. Yeah.
So the brain, sleep disruption, cognitive changes, and mental health changes. Mm-hmm. So 40% of women get a mental health new diagnosis or exacerbation of a diagnosis. Those are the women going in to get treated. How many of us are not going in and just like toughing it out? So why is this happening? Well, it turns out our neurotransmitters, things like norepinephrine, especially dopamine and serotonin, these are the chemicals that talk to the neurons in our brains and transmit signals back and forth. Those levels change dramatically when the sex hormone levels start rising and falling, okay? Also, the way and this is Lisa Mosconi's work, the way we utilize glucose in the brain changes, especially in the amygdala, which controls our emotions, and in the frontal cortex, that makes memories. So it's predictable that you're gonna have mental health changes. It's predictable you're gonna have brain fog. We rewire our whole brains through perimenopause and into menopause.
This feels like it was worth more than an hour in medical school.
I think so now. If I had my way, if I could control the ACGME, things would be very different.
Yeah. So there's no specific lab test that can tell you you're in perimenopause. So when I go to my doctor and I say, I think I'm in perimenopause, and she says, we're going to run some labs, what does that mean?
So we're really good at telling you if you're postmenopausal. We've known that for a long time. We check an estradiol level and you have none. And we check an FSH, and that's that stimulating hormone, follicular stimulating hormone, and it's elevated above 50, okay? That's diagnostic. If you're over the age of 45 and you have not had a period for 1 year, that is also a definition of menopause. Now, what if, and now I was taught all of that, I knew all of this, okay? What if you've had a hysterectomy? What if you were born without a uterus? What if you have an IUD that stops your periods? Like, do you not get to be menopausal by that definition? What if it's leap year? Do you have to go 366 days? It really is using symptoms to define something we know is medically very, very different. You know, it is cessation of the ovary's ability to produce sex hormones from the ovaries.
Yeah. So what are you hoping that they test you for versus?
So in our clinic, in perimenopause, we don't do a lot of hormone testing.
Okay.
If she's having desire disorder, we can get into that later. I'll check a testosterone level because we're going to talk about that in treatment.
Okay.
But estradiol, a one-time estradiol, you know, FSH, any one-time blood, urine, saliva test is not going to be diagnostic because of that chaos, right? Where are we in the program? We'll try to get a day 3 sometimes, you know, where we know the levels should be low to kind of see where their FSH is at that point. But it's not really, we do not have a great diagnostic test for this. But if you talk to the patient and you let her talk and you listen to her and you believe her, you can make the diagnosis. Now, contrary to what I say, you know, what you might believe, not everything is perimenopause. Sometimes. So I do a lot of blood work. So I am looking at all the basic stuff she would get at a well-woman exam, but we're also getting advanced lipid panels. You know, a rising LDL, a rising ApoB will often give a diagnostic clue. A rising insulin resistance score, a HOMA-IR score, can be very, very helpful for these patients. Also help you to, you know, make some diagnoses and give her better counseling. We're checking things like ferritin. I'm checking thyroid levels. We're, you know, lots of things will overlap. And so we are doing a ton of blood work on our patients and really just helping, you know, when they come to my clinic, I like to say we put out the fire of menopause. They just want to be functional.
Yeah.
Again, give me my life back. I'm not asking to be a supermodel. I'm not asking to be, I just want to be able to manage this beautiful life that I've built.
Right.
And they've lost their resilience.
Yeah.
You know, they're not rolling with the punches.
Yep.
And so we give them that back. Then we start looking at the next 30 years. What's it going to take to, and I call it the nursing home prevention program. What is it going to take to keep you out of, look at your mom, look at your grandmother, how did the aunts in your family do? How are they aging? Does everybody have osteoporosis? Are they fracturing? Do they all have dementia? Like, you know, we know what the biological causes of these things are and how we can prevent it, right?
Yeah.
It's not all HRT, it is lifestyle, it is nutrition, it is stress reduction, it is sleep. I'm giving patients permission to say no, to put up boundaries, to put their health first for the first time in their lives.
Okay, let's talk about that for a second, because I do think there's a tension between sort of, and you're very clear in the book, you can't wellness your way through perimenopause. At the same time, there are wellness approaches that will ease your time and your symptoms, and as you say, prevent all of these things 10, 20, 30 years down the road. So talk a little bit about that balance.
Yeah, so I call it the menopause toolkit, you know, because it's not just slap an estrogen patch on someone and go and be free and you're gonna be healthy for the rest of your life. That's not how it works, right? Hormone therapy can be life-changing for patients. And in perimenopause, especially with mental health, we're learning so much right now about it, especially in menopause hormone therapy is FDA approved for the prevention of osteoporosis. The only medicine we have for that. And so, you know, these are the conversations we have, but you cannot talk about that and then not talk about lifestyle. her nutrition, where's she getting, how much protein is she getting? There's so much misunderstanding around that. Like, what kind of exercise? Like, most of my patients walk, right? And so if you're walking, let's weight the walk. We have to really rethink, instead of dieting and trying to be smaller and, just that, I think part of the epidemic of osteoporosis in this country, and I'm just gonna call it an epidemic because none of us should have it, is we've took generations of women and tried to force them to be in smaller bodies than they should have been, right? And this constant dieting of trying to look like a 14-year-old is destroying our health in ways we never expected. And so, in our clinic, we measure body composition. I'm able to talk to her about her muscle mass. I can't tell you how many tears I have dried from telling a woman she is strong.
Yeah.
And how proud I am of her, of all of the muscle she has. And she's rocking some curves, but who cares? That's not gonna hurt her,
right?
And so if she has visceral fat, that's a different animal. We talk about that and ways we can manage that. GLP-1s can be very helpful for that, but it's a much bigger picture than just an estrogen patch.
Yeah. I feel like you want us to have a lot of fiber.
Yes. Yes.
Why do you love fiber so much?
I love fiber. Well, first of all, here's what we know. We're not getting enough. And foods that are rich in fiber are things that nuts, seeds, fruits, vegetables, and legumes, beans, basically. And we know lots of things about people who have high fiber diets naturally. They have less heart attacks, they live longer, they have less all-cause mortality, they have less strokes, they have less diabetes, okay? For gut health, and also, we're learning leaps and bounds about gut health. Was like woo-woo back when I was in residency, and now it's everything. And
now
gut
it has
health,
influencers.
yeah. And so, you don't have to take a supplement. This is a doctor who sells a fiber supplement. My goal is to please put me out of business. Eat enough fiber where you don't have to buy mine. And so, but it's hard. And women need, for gut health, somewhere around 25 grams per day. But for cardiovascular health, it's 35. So we kind of shoot in the middle. I'm telling my patients we're going to shoot for 30. Most women are getting 10 to 12. Like, how many calories have you counted your whole life and nobody ever talked to you about fiber? In our clinic, I'm like, you need to eat more. And they're like, what? After a lifetime of being brainwashed into thin is the only way, work out more, eat less, cardio, and they were sacrificing potentially bone and muscle strength to try to be in a smaller body. Take up space.
Yeah. Love it. Okay, we've danced around this a little bit, but let's talk more about irritability.
What about it?
Well, I feel like it's one of those things that it's kind of a punchline on a lot of perimenopause and menopause reels, right? It's sort of like, do you need hormone replacement or do you need a divorce? Right?
Yeah.
But it is real.
Yeah.
So
the
validate
amygdala that controls our emotion glitches a lot in perimenopause with all these fluctuation. It does tend to kind of calm down. So a lot of the brain symptoms, except for sleep, do get better after the brain rewires. We become better problem solvers in our 60s and 70s. We, so many things about the brain get better for women as we age, but we kind of lose our shit for 10 years.
Okay.
And so the irritability is lots of things. So one, the amygdala is glitching, and so your usual kind of code, you start code switching, but you also are starting to come to some realizations of you're not going to put up with stuff anymore. It is one of the magical things about menopause. You start circling the wagons around yourself, your needs, your desires, your health, and I love seeing that in my patients, and so sometimes the irritability is they're just not willing to put up with people's shit anymore.
Well, right, and I see it framed as that too, right?
So sometimes that does mean you need a divorce.
Yeah, right. Yeah, been there, done that. You also see it framed as I have no more blanks to give, right?
Right.
And
the bucket is empty.
Yeah, right. But is that because our lived experiences have caught up to us at the same age that our zone of chaos is occurring? Or
I think it's all part of it.
Okay.
And we're in this incredible sandwich generation, and when my patients come in, I don't have a single patient yet, and I'm sure it'll happen, who's like, Dr. Haber, I want to live to 120. I want to be the female Brian Johnson. None. They were like, why would I want to live that long? Like,
I'm so tired.
I'm so tired, yeah. Like, I just don't want to lose my independence as I age. I want to stay as functional as possible. I don't want to have anyone cook for me, clean for me, drive for me. You know, I want to be able to wipe my own hiney. I want to, you know, like, for as long as possible.
Yeah.
And so I don't take care of men. Do they say that to anybody who takes care of men patients? I think they just realize someone will do it for them and they're not going to worry about it. And so, but like the women, because they've done it for their mothers.
Right.
They've taken care of their parents, you know, are looking, and I have this, you know, we're going through it with our parents, my husband's here, in different degrees. And it's like, okay, I'm going to plan for this. Mm-hmm. I want things to be different for my children when it's my turn to like be old. Mm-hmm. And I think that it just gives them this clarity around, how do I want to live the next 30 years?
Yeah. And I want to be empowered to choose how the next 30 years look, right?
I think for so long our mothers generate, well, so I'm a Gen Xer. Yeah. And I don't think my mom thought she had a choice, right? Like it was what it was going to be. Right. And so my grandmother had horrible osteoporotic fractures and we now know as Alzheimer's, but we just called it dementia back then.
Yeah.
And kind of wasted away the last 10 years and needed a lot of help, you know, just lost all independence. And I think my mom just was like, well, that's going to be my path. You know, no one told her about strength training and protein intake and quitting smoking and alcohol and not eating processed foods and getting enough sleep and, you know, like all of the things we now know are risk factors for all these chronic diseases that women tend to suffer from way more than men. And so that so much of this could have been preventable. And I just refuse for that to be a reality for my daughters.
Absolutely. Absolutely. And I'm my mind's spinning from the things that you wrote in the book that are reminding me of things you're saying now. But one of them, when you say so many women felt like they didn't have a choice, how many patients you talk to who aren't sure why they got a hysterectomy?
Oh my God.
Or not necessarily patients, but women you talk to who say, yeah, why did you need the hysterectomy?
It was time.
I don't know. Because I was done having kids. I didn't need it anymore. Like these answers that are like, a doctor just said, that's what you're doing. And now everything's affected.
Yeah.
So talk a little bit about that.
We need hysterectomies. I do not want to like bash on the needed hysterectomy, but I think for a generation, it was used as birth control. It was used as, oh, you don't need a period anymore. There were a lot of, when they looked at the pathology, so every time they take an organ out of your body in a modern hospital, it gets cut up and put in slides and they look at it for cancer, okay? So there was a study where they went back and looked at the pathology looked for pathology in these uteruses that were removed, and in like 80% of the cases, they didn't find any. They were healthy uteruses that were removed for convenience, or I don't even know why, and so I was not trained to do that, to be sure, but I'm taking care of patients who could not tell. To this day, I'll have a handful of patients a week who cannot tell me why exactly they had a hysterectomy. And so, we need to be proactive in our own care. We need to understand why people recommend procedures and what your options are, I've done hysterectomies. They are so needed. They can be life-changing. But I think a lot of people, what I was never taught to counsel patients on is, on average, if they leave your ovaries behind, you will go through menopause 4 years sooner than you did if they left them, because we lose some blood flow there. And no one taught me that could be a thing. I mean, it's important to know. So we look sooner for the symptoms. We counsel the patients. I mean, if you have to have hysterectomy and that's your best medical option, absolutely have it done. But I think we're getting up to speed on what the downstream effects could be and how to properly counsel patients about it.
Yeah. I hear you say that we need to be proactive about our care, and I know there are people in the audience who are feeling like, yeah, I'm trying and my doctor doesn't listen, or I'm trying and I don't know the right questions to ask. Shouldn't the doctor know the right questions to ask?
So we weren't trained, okay? If those of us in the room who do menopause care sought training outside of our traditional training programs, women's health outside of reproduction, and let me be clear, has never been prioritized. Most of
Or
the medications
funded.
you are taking for your cholesterol and your heart disease or your whatever were studied in men and are very few women. And so we are fighting to change that. And women are owed centuries of research. Centuries. I'm quoting Lisa Mosconi. And the default has always been the male body as normal, and anything different was considered, like chest pain. When we look at how women have, women disease differently than men in the same organ. And the heart is one of the best examples. So men tend to have the big widowmaker, the big blockage in the artery right as it leaves, right as it dives into the heart muscle. I'm trying to simplify the language. And women tend to have diffuse microvascular disease way deeper in the heart muscle. So when a man has a heart attack, it's like a lightning bolt, right? The artery gets smaller and smaller until it plugs, and then boom, massive, the Hollywood heart attack, chest pain, his jaw hurts, fall on the ground. Of course, some hot woman starts CPR and he comes back to life. But women, because their disease tends to be deeply infiltrated in small, little speckles all over the heart muscle, ends up with nausea and abdominal pain and just very vague, and it goes on for weeks and weeks and weeks. She's tired, she's sleeping a little bit longer, her feet are starting to swell, and so that's called atypical chest pain. We are 51% of the population. Why is my heart attack atypical and not my husband's?
Right.
So they are 50% more likely to be discharged from the hospital while having a heart attack. They are much more likely to die from a primary heart attack to a man. So, and we're using the same protocols, and there are massive sex-based differences in how we disease and how we age. And that's what we're fighting for. Menopause is the tip of the iceberg.
Yeah. And we could get into how women's health is not funded in the same way, the research around it and all
I was
of that.
told not to talk about politics.
Okay, so we won't do that. Never mind.
Vote.
Yeah, the answer is vote. Yeah, the answer is always vote. So you're very candid in the book about why you're addressing menopause and sexual function. And part of it is because for many years, you look back on the advice you gave your patients and you regret it, correct?
Drink wine.
You told them to drink wine. Has anyone ever been told to drink wine by their doctor when you don't have to raise your hands.
Relax.
Some of you
Go on a
have.
vacation.
Yeah, bubble bath. Yeah.
I mean, give her a sedative, put her in a toxic bubble bath that's going to hurt her vulva. Like all the things. I'm like, no one taught me, and I was just winging it. I read Venus and Mars in the bedroom by myself. Like I didn't know what to do because I get out of my newly minted OB-GYN residency. I can deliver the shit out of a baby, right? All my patients want to talk about is sex.
Yeah.
And I'm like, what's happening? I don't know anything. And so I go to my older partners and they're like, tell her to have some wine. Tell her to relax. Tell her it's going to be okay. Just don't use it or lose it. It's all bullshit. There's medical reasons that we can help people with. And I learned none of this.
Yep. I wrote down this quote because I love it so much. So you said, female desire isn't a switch, it's more like a cockpit of a 747. Complex, dynamic, and highly sensitive to internal and external cues, right? And those cues can be history, stress, safety, self-image, your partnership, name it. Perimenopause comes along, and all of a sudden that cockpit is like real hard to navigate.
Cockpit goes way over there.
Okay, yeah. So explain why and what to do about it.
So I wish I had an easy answer, easy Band-Aid, right?
There is no easy answer Band-Aid to any of this, right? I mean, that's sort of the theme of the night,
So
right?
when we look at, a woman comes into my office and says, I'm not happy with my sex life. Okay. What does that mean? So we kind of have buckets of things that might be in the buckets can overlap. We have relationship disorders. I'm like, do you love your partner? Is there a problem there? Do you communicate? Do you feel supported? And if she's like, oh my God, I love him, I love her, whatever, like they're amazing, and I feel terrible about this. One, it has to be a problem. But if you don't care if you never want to have sex again, that's fine too. So let's just normalize that, okay? It must be a problem. And so I'll say, did you ever have desire, is this ever a good idea to you? Yes, it used to be amazing, and I can't get there anymore. There's something, so that's really the desire issue. So we have a relationship issue. If you don't feel loved, supported, you don't like the person, that's a problem I can't fix, okay? And then we have desire issue, that's in the brain, okay? Hormones feed into that, stress, body image, all the things, right? That's the cockpit, very, very complicated, but we can usually navigate through that with the patient. There could be an arousal disorder. Everything's functioning up here, but we can't get blood to the area, from a nerve conduction disorder, from a, blocked vessels. You can have atherosclerosis down there, and so there are medications, we can have erectile dysfunction in women. The clitoris can't get the blood where it needs to, just like the penis, and they're analogous organs, right? So we use the same medications. We can use sildenafil, Viagra basically, to treat that, to help treat that in a woman. Then we have pain. Does it hurt? Are you getting enough lubrication? How do you, we have to fix the pain. And if it's GSM, genital urinary syndrome and menopause, we have easy ways to fix that. Just most women don't realize that's a thing. So we have to determine what's going on, what of these buckets is happening, how are we gonna address them? And so if it's pure desire, so no, it doesn't hurt, I'm getting blood flow, I can orgasm, it's still happening. Oh, and the other thing most of y'all may start realizing is the delay. You can orgasm, but it's taking longer. That's usually a blood flow issue. And so we have ways to help improve blood flow to the area. So if it's desire, if we're trying to help her brain, okay, there's testosterone has been studied in postmenopausal women, and about 50% can be helpful. And we're not talking chandeliers and you're 23 again, but it is an uptick in the area, right? You uptick in your interest, and it's suddenly more interesting. Maybe you're initiating again or something, and the patients are very happy with that. I don't like to sit here and measure how many times you're doing it a week, or, and like Kelly Casperson talks about, is it sex worth having? Were you having good sex? None of us got that kind of sex. I know we're in a Catholic school. I went to Catholic school. We would never talk about this. So I'm like, I'm sorry, Jesus.
Jesus is so mad right now.
No, I think he's happy. He wants us to have good sex with our husbands.
I totally agree.
Yes. No, in my pre-Cana, they said Jesus should be standing at the end of your bed clapping. That was a little freaky. I was like,
I should have gone to pre-Cana.
I don't need that image. It's enough. I went to Catholic school, please. No.
Let's just pretend that our doctors don't talk to us about those things. How do we bring them up, and how do we push back when we feel like we're being dismissed?
If it's your sexual function or even just menopause care, it's not reasonable to assume that your awesome OBGYN, your internist, your family medicine doctor, the people who are supposed to know about this, they really probably weren't trained, especially for sexual health. And so thankfully we have things like the Menopause Society, menopause.org. You can go and find a certified provider. On our website, I have thousands of women who gracefully wrote testimonials of their doctors and their experiences, and it's all free. You can go and download them by city and state, okay, to help you find someone. ISHWISH, International Sexual, help me, Samina, what is the... Okay, International Society for the Study of Women's Sexual Health. I'll never remember this again, but it's ISHWISH in my brain. And so it is a society just for studying women's sexual health. And it's, you can go get you can be a member there. So you can find their members on the website if you're looking specifically for sexual health. So these things are nuanced, they're complicated. It's not a Band-Aid. Don't let anyone tell you, just take testosterone, your sex life will be amazing. I mean, it might, but probably not. You deserve a full visit, you deserve a full exam, you deserve people who know what they're doing and who care about this. And sometimes you're gonna have to step away from the traditional the insurance based, a lot of us they won't give us enough time to do these exams, to do the counseling, to do, it's hard. And this is not a well woman exam, any of this. That is your screening for breast and cervical cancer and some blood work, okay? As an OB-GYN, we're busy delivering babies, running back and forth, pap smears, hysterectomy. Menopause takes time, and unfortunately our administrators just don't give us the time to get it done right.
Yeah.
So it's about probably 4 visits, and they're all problem visits, I think, to do it well.
Okay. And the book has resources about how to find doctors who are menopause trained. I'm sure all of the websites you just said are in there, because it's the end of the book is very, very useful and resource packed.
I tried.
So thank you for that. I know a lot of people in the room, including myself, have hormone replacement therapy questions. Is there an average correct amount of time to stay on it, or make sure you don't stay on it past if you do go the hormone replacement therapy route?
There's no age at which you must stop.
Okay.
To be clear.
Okay.
So Menopause Society is clear about that. And if you're on it and you're happy and it's doing what it's supposed to be doing for you and you want to keep going and you have not developed a contraindication, there's no magical 60 or 65 where it turns black and falls off your body and you're going to die. So like that doesn't happen. And so I might die with an estradiol patch on. Maybe. They're going to open my casket and there'll be some bones and a little plastic thing sitting on my hip bone. And but if I develop a contraindication, I'll have that discussion with my clinician.
What would a contraindication look like?
Okay, if I developed a tumor that was being fed by the hormone, I'm coming off.
Okay.
Till my treatment's done and we reevaluate.
Okay. Yeah.
If I develop severe liver disease, if I have undiagnosed vaginal bleeding, those are all indications we're not right now. If I get pregnant, pregnancy is a contraindication. I'm like, I'm 57, I'm not getting pregnant.
I see Lonnie, so we must be running close to time. Why do some of us grow like weird facial hair?
Yeah, one of the gifts.
Asking for a friend.
Gifts of menopause. I was on the phone. Do y'all follow Jen Hamilton? She's going to interview me in North Carolina. And she's a labor and delivery nurse with a huge following, so she's going to be my MC. Anyway, I'm talking to her about the interview, and I go, oh my God, I just found a chin hair.
Always.
She's like, is that what I have to look forward to?
Yeah.
It's like, yeah. I was like, it's like a foot long already. Like, when did this happen?
In the last 5 minutes.
Yeah. Like I can feel it. So anyway, there's hormone changes associated. Sometimes testosterone can do it. Sometimes the way that hormones are carried in our blood, or SHBG, can change. Fortunately, the hair loss is a little easier harder to deal with. The hair gaining, we have lots of cosmetic ways to manage that and some medications as well.
Okay. Normal though.
Yeah.
Okay. All right. I will allow this conversation to wind to a close so audience questions can get asked. I love that you ended the book with a letter to your 35-year-old self. And I wonder if you could just talk about what made you decide to do that.
Because I have daughters, my girls, they're 22 and 25 and slightly horrified that I talk about menopause all day. But these are the things that, and the letter is, I've lost 3 brothers. I'm gonna get teary. And this is the year that I survived them all. So I'm getting the years they never got. And I don't want to take that for granted, and like at 35, a million years ago, almost 20 years ago, 22 years ago, I was, they were little. I had just had Maddie. Catherine was 4. My husband we were working so much, so hard, and just, nannies and the scheduling and all the things and all the stuff I took for granted. I wasn't looking after my bone health or my muscle health, and I was thin, so I thought I was fine, and just the stress and the little things that I let get to me. And that to slow down a little bit and take a breath, and they're gonna grow up and they're gonna leave you and you're gonna lose these brothers, and just realize these things. And menopause is coming, and educate yourself. Don't be scared of it. I'm on the other side. I'm living my absolute best life at 57. So, and I've changed everything about how I take care of myself. You know, I prioritize my health. I put myself first. I say what I want. I say no. I put up boundaries. You know, I left a prestigious academic position to do something I knew I had to do, which was take care of women at this stage of life only.
Yeah. Well, thank you for giving us a blueprint to do the same.